Good evening, and thank you for joining us for Musculoskeletal Health Australia's 2025 Koadlow Lecture. My name is Helen Jets, and I am the Chief Executive Officer of MHA. And on behalf of Musculoskeletal Health Australia's Board Chair, Jade Rowett, the directors and staff, welcome. I would like to take this opportunity to acknowledge the traditional owners of the lands from which we are joining you for this evening's lecture. On behalf of Musculoskeletal Health Australia, I pay my respects to the traditional owners and custodians of these lands and acknowledge and uphold the traditional owners' continuing relationship to the land and waterways. The culmination of Musculoskeletal Health Awareness Month each year is the prestigious Koadlow Lecture. Established in 2009, each year, MHA is privileged to welcome world-class experts and leaders from a broad cross-section of health as our orators. Previous orators have included Professor Peter Chung, Professor Lorimer Mosley, and Professor Peter O'Sullivan. The lecture was named in recognition of MHA's founder and pioneer in musculoskeletal health and well-being, Dr. Leslie Koadlow. Dr. Koadlow was a passionate rheumatologist who, alongside Alice Petty and Molly Richards, established MHA in 1968. I would like to take this opportunity to welcome and acknowledge the Koadlow family who join us this evening and thank Dr. Koadlow's children, Peter and Jenny, for their ongoing support of our organisation and the work we do. Keeping with the Koadlow lecture tradition, it is now my honour to introduce this evening's incredible orator. Gerald Quigley, Musculoskeletal Health Awareness Month Ambassador, practicing community pharmacist, recognised health expert and media health commentator, master herbalist and author. You will no doubt recognise Gerald from his work on the House of Wellness, or via his countless other radio, television, written and online activities. He is a passionate health advocate and one of the most incredible representatives for healthy living and movement at any age. His oration this evening will explore the role movement and physical activity has in establishing and maintaining musculoskeletal health. Gerald will certainly challenge us, make us think about movement and the importance of good musculoskeletal health and its integral relationship with our overall health and well-being. On behalf of Musculoskeletal Health Australia, it is my great honour to welcome Gerald to deliver the 2025 Koadlow Lecture.
Thank you, Helen, and an absolute privilege to be here in delivering this very special, prestigious lecture. And I too want to thank you very much for allowing me to be the Musculoskeletal Health Australia Awareness Month Ambassador, which has been a lot of fun and one that we really have been working hard to make sure that we try and get the message across as much as we can. And at the outset, may I pay as well a small tribute to the gentleman to whom this address is devoted. And I refer to a farewell written by Heather Rose, the Life Governor and Board Member of Arthritis Australia. I'm a bit of a traditionalist and I think we should remember history and we should also recognise that these things are meant to last for perpetuity, and we thank very much those who have gone before us. And organisations like Musculoskeletal Health Australia don't just happen. Fundamental issues need to be constantly addressed, problems solved, hurdles overcome, all with a renewed focus on patient care. Dr. Koadlow died in April 2006, aged 85. He worked constantly to ensure that instead of becoming passive receivers of services, people with arthritis remained active, contributing members of the community. His commitment to empowering people with musculoskeletal conditions to be partners in their own treatment saw him practicing medicine 40 years ago in ways that are now recognised as best practice. In 1963, Dr. Koadlow began the first Victorian self-help group for people with arthritis from amongst his patients at Prince Henry's Hospital. He held public meetings for people with arthritis who were hungry for information and help. It then became his mission to foster the formation of a community organisation to support people with arthritis. He envisaged an organisation that could provide improved health education services, academic support, and crucially, communication between those affected. He realised what a difference such an organisation could make to many lives, and that such measures could empower people so that though some may have some physical disabilities, their spirit and dignity could remain intact. Dr. Koadlow will be warmly remembered for his effective and generous counsel. He had a lifelong concern for people and an acute sensitivity towards another's pain. He had an extraordinary humane approach to life and a deep concern for the disadvantaged. With all his skills, he was the most unpretentious man. He treated each patient as a friend, and almost everyone leaving his rooms did so with a laugh or a smile. I have fond memories of being involved with some of his patients when they presented prescriptions that were written by him. Each person seemed to speak spontaneously of his good nature. That's how long I've been around. Now let's get into our topic for this evening. And we've titled that Movement is Medicine. At last, we're starting to apply the principles of movement and seeing why good musculoskeletal health is essential to overall health and well-being at all ages, and I prefer to call that our quality of life. There are many versions of what and how we interpret movement. And I'd like to say that movement, body movement, explores how our body moves around in order to enhance performance, prevent injuries, and for rehabilitation after injury, covering areas from sports and exercise to daily function. In a recent study published in the British Journal of Sports Medicine, a group of researchers assessed the impact of low physical activity on life expectancy and potential gains from increased activity at individual and population levels. The study underscores the profound impact of physical activity on life expectancy, particularly amongst those who are least active individuals. Modest increases in physical activity, such as an hour of daily walking, can translate to significant gains, adding up to 6 hours of life expectancy per additional walking hour. The analysis improves on previous self-reported estimates using precise accelerometer data, revealing a stronger association between physical activity and reduced mortality. The findings advocate for greater investment in physical activity promoting environments and policies, such as urban planning initiatives, active transport, and increased access to green spaces, allowing population level improvements in health. Another article in the Journal of Aging Research explores the topic, does physical activity increase life expectancy? A review of the literature. I'll share the findings. Physical activity reduces many major mortality risk factors, including arterial hypertension, diabetes mellitus type 2, dyslipidemia, coronary artery disease, stroke, and cancer. All-cause mortality is decreased by about 30 to 35% in physically active as compared to inactive subjects. The purpose of the paper was to synthesize the literature on life expectancy in relation to physical activity. A systematic PubMed search on life expectancy found 35 research studies on this issue. On that basis, I'm therefore puzzled that movement doesn't feature more in medical consultations. However, has the idea of movement in its own gentle implication been hijacked by the exercise industry? Special shoes, colourful lycra, lots of sweating, huffing and puffing, along with obvious and perceived suffering, encourages a pushback for many people who might be concerned about their own body image or whether they're actually cut out for any exercise at all. Perhaps over time, we've accepted that there's a pill for every ill. If you're overweight, take a pill, but you can't actually take a pill to make you move. Human movement, on the other hand, is a change in position or posture of our actual body, driven by our musculoskeletal structure of muscles, bones, joints, and ligaments. This is all controlled by our nervous system. Human movement involves the complex interaction of these systems to produce coordinated, purposeful motions, from simple actions, from blinking our eyelids to complex athletic feats. The study of human movement analyses the mechanical, physiological, and neurological factors involved in these processes. There are many ramifications attached to reduced movement as we age. Chronic diseases such as heart disease, diabetes, and obesity are significant contributors to morbidity and mortality worldwide. The rise in these conditions is often attributed to lifestyle factors, amongst which physical activity is a predominant one. Regular movement and physical activity can be pivotal in preventing and managing these diseases. Despite the well-documented benefits of movement, various barriers hinder individuals from engaging in regular physical activity. These can include societal factors, environmental limitations, and personal challenges such as a lack of motivation or understanding of effective exercises. Overcoming these barriers through education and community programs is essential for fostering a culture of movement. Novel research shows that in approximately 1/3 of countries and territories worldwide, population ageing was the largest contributor to the growing burden of musculoskeletal disorders from 1990 to 2021. The new study in the Annals of Rheumatic Diseases, published by Elsevier, is poised to inform targeted public health strategies and healthcare resource allocation to alleviate the global burden and economic impact of these disorders. The key findings include, in about 1/3 of countries and territories, population ageing was the largest contributor to the increasing burden of musculoskeletal disorders. Middle-income countries bore the highest proportional burden of musculoskeletal disorders from population ageing, despite having younger populations than high-income countries. This reflects the rapid demographic shift in these countries, combined with limited health system readiness to meet older adults' needs. Globally, men experience greater impact of population ageing, particularly in high and high-middle income countries. Women were more affected in low to middle income countries. Osteoarthritis was the most affected musculoskeletal disorder globally, followed by gout and rheumatoid arthritis. Population aging-related musculoskeletal disorders cost $96 billion in global healthcare costs in 2021, equivalent to 0.1% of the gross global domestic product, surpassing the costs attributed to common modifiable risk factors. Lead investigators noted that these results can help policymakers prioritise interventions tailored to socio-demographic context, sex differences, and specific musculoskeletal disorders, including strengthening preventative measures, improving long-term management, and ensuring sustainable financing to address the rising costs attributed to population ageing. Ultimately, this could reduce disability, improve quality of life for older adults, and make healthcare systems more resilient. The study is a wake-up call for politicians and other stakeholders to focus research efforts on understanding, preventing, and treating musculoskeletal disorders such as osteoarthritis and rheumatoid arthritis in an ageing population to ensure healthy with the best quality of life. And perhaps we should focus on the word movement instead of exercise. As I mentioned, the latter implies real effort, a more solid commitment, new footwear, new exercise gear, maybe even joining a gym. As attractive as that might seem to some people, movement is a more gentle way of doing just that as part of a daily routine. The Australian Government Department of Health has physical activity guidelines on their website. The physical activity guidelines for older Australians lists the following. Think of movement as an opportunity, not an inconvenience. Be active every day in as many ways as you can. Put together at least 30 minutes of moderate intensity physical exercise on most, preferably all days. And if you can, also enjoy some regular vigorous activity for extra health and fitness. And the guidelines go a little further. Build exercising into your daily routine. Try to reduce the amount of time you spend sitting. Some exercises can be easily built into your existing routine. For example, you could do shoulder rolls while waiting for the kettle to boil, or some heel and toe raises while you're watching TV. And it is good to include a range of different types of activities throughout your week. These are the guidelines, but perhaps they're a little too generalised. What exactly is moderate intensity exercise? What if I have got some sort of physical impediment? Where do I go? What do I do? Many of us try to focus on the holistic aspects of chronic disease management, whereby we encourage our patients to understand what role they may be able to play so that they can live with their particular disease and not be dominated by that disease. Doesn't that take us back to the original thoughts of Dr. Koadlow? Chronic diseases such as heart disease, diabetes and obesity are significant contributors to morbidity and mortality Australia-wide. The rise in these conditions is often attributed to lifestyle factors, amongst which physical activity is a predominant one. Regular movement and physical activity are pivotal in preventing and managing these diseases. Understanding chronic disease is a real challenge to our patients. These health challenges are prolonged conditions that generally do not resolve spontaneously. They encompass a wide range of illnesses, cardiovascular diseases, diabetes, obesity, and some cancers. Understanding the risk factors, which include obesity, diet, smoking, and inactivity, is crucial for effective prevention strategies. Movement encompasses any form of physical activity and is vital, as we know, for maintaining health. The World Health Organization recommends regular physical activity, highlighting its benefits for individuals of all ages. This includes a mix of aerobic activities, strength training, and flexibility exercises. Physical activity contributes to improved cardiovascular health by enhancing heart efficiency and lowering blood pressure. It plays a vital role in metabolic regulation, helping to manage blood sugar levels, thereby reducing the risk of type 2 diabetes. Regular movement helps in weight management, boosts immune function, and fosters mental well-being, all of which are critical factors in chronic disease prevention. Let's look at some of these specific benefits in addressing chronic disease. For cardiovascular diseases, aerobic exercises improve heart health by reducing blood pressure and managing cholesterol levels. A study titled "The Impact of Aerobic Exercise on HDL Quantity and Quality, a Narrative Review" explains further. The presented data suggests that favourable effects of aerobic exercise training on lipid and lipoprotein profiles. The impact of aerobic exercise on HDL, that's the good cholesterol, on HDL function depends on several factors, including exercise type, intensity and duration, as well as participant characteristics like age, race, body mass, baseline HDL levels, diet and medications. Therefore, studies provide sometimes conflicting results. Regular physical exercise improves vascular function, for example, endothelium-dependent vasodilation, via the effect on vascular structure and vascular cell functions. Various mechanosensory mechanisms have been suggested to mediate the effects of exercise on vascular function. The effects of repeated acute physical activities with low intensity may produce minor changes that may not be noticeable in clinical trials. However, frequent repetitions of single sessions may result in lasting adaptations, called the chronic effect. And therefore, even a small quantitative effect should not discourage us from adopting an active lifestyle and starting a structured exercise program. Surely, the combination of lipid interventions, including diet, medication, and appropriate exercise training, would prove beneficial and facilitate the optimisation of individualised medical management for lipid disorders. In the case of diabetes, consistent physical activity helps to reduce insulin and blood glucose levels, significantly reducing the risk of type 2 diabetes development. Research indicates that regular movement is linked to reduced cancer risk and may improve recovery outcomes in cancer survivors. Indeed, at a recent lecture by an oncologist who specialises in ovarian cancer, her view is this: to reduce overall risk of cancer, exercise now. If you feel that you are exercising, then exercise more. And that was a very impactful statement to her audience. Being physically active has several benefits for people with cancer, and these include reducing anxiety, improving depression, improving sleep quality, and reducing difficulty falling or staying asleep, reducing fatigue and pain, improving your overall enjoyment of life, there's the quality of life I've mentioned, improving body strength, reducing treatment side effects such as heart changes, nerve changes, peripheral neuropathy is very common, during or after chemotherapy, thinking problems, so cognitive impairment, and shortness of breath. As well, being physically active improves physical health in women with breast cancer who develop lymphedema, which is a type of swelling caused by treatment to lymph nodes, and it improves general physical functioning. Researchers feel that adding exercise to cancer treatment plans could help people cope better, but more research is needed. And this will help us know exactly how exercise helps and to provide exercise prescriptions according to the type of cancer one has. Some earlier studies show that physical activity may help treatment work better, but we need more research to understand this. Barriers to physical activity arise from all directions. These barriers might be societal, for example, girls foregoing exercise, where issues around body image start impacting, or environmental, where appropriate safe space isn't allocated for physical activity. The barriers might be personal, involving lack of motivation or lack of knowledge about the benefits of actual movement. Many of these barriers can easily be removed by more community involvement. That might mean that local councils refocus on providing easy and free access to areas and buildings at no cost to participants. I realise that roads and rates and rubbish have been well-established areas of local council involvement, but distractions in other quarters might have meant that the ratepayer and his or her family might be unable to gain the benefits which movement offers. So just imagine a movement program led by trained instructors across each day, offering different activities and times to we the public. That could involve local schools as well, many of which are unused at various times. That's going to present a lot of challenges, I know. You can imagine risk insurance, property insurance, injury insurance, equipment insurance, personal liability insurance, security, and no doubt a host of others. But did I mention barriers? And I might be a little facetious, but I would imagine that there would need to be some sort of cost-benefit analysis, a committee of some sort involving a number of very important people, but it might be years before anything substantial might happen. We've got to cut through all of that if we can. Governments need to see cost savings as a basic requirement for any financial subsidies, but it is possible. We would all agree that the cost savings to the health of Australians and the Australian taxpayer would be substantial. Community initiatives promoting movement might reward councils for their foresight. Private health insurance companies might be used to encourage participation by their members. There's also a focus on mental health and exercise. A recent peer-reviewed paper in Medicine Today looked at the physical health of patients with mental illness, looking at complex interactions requiring complex interventions, and the focus was on those with schizophrenia. In essence, the physical health of people with schizophrenia can be compromised due to the dynamic interplay between numerous additive risk factors, which result in considerable morbidity and mortality. Importantly, many of these risks are readily modifiable in general practice setting through the provision of patient health education, thorough and regular screening, and early intervention and directed treatment. I'd like to explore this a little closely as an example of the role of movement here. Imagine the benefits across the board when some or all of these considerations are implemented. As I mentioned, schizophrenia significantly increases the risk of comorbid physical health conditions, particularly cardiovascular disease and diabetes, leading to significantly elevated risks of morbidity and early mortality. Iatrogenic factors such as metabolic side effects of antipsychotic medications, further complicating the physical health of individuals with schizophrenia, increasing the risk of metabolic syndrome and related diseases. General practitioners play an important role in the assessment and management of both the mental and physical health of people with schizophrenia through early intervention, patient education, and appropriate on-referral. Barriers to physical health care for people with schizophrenia include social isolation, stigma, and difficulty of accessing health care, and that contributes to delayed diagnosis and care disruption. Collaboration between general practitioners, psychiatrists, and all of we healthcare providers, along with the use of shared care models, can improve the overall health and quality of life for people with schizophrenia. We're well aware that type 2 diabetes is out of control in Australia. All sorts of recommendations are being made, but it's a bit like law and order. Enforcement is the missing component. We know that insulin action in muscle and liver can be modified by acute bouts of exercise and by regular physical activity. A big study looking at physical activity in adults with type 2 diabetes showed that intensive lifestyle interventions achieved improvements in weight loss, cardiorespiratory fitness, blood glucose control, blood pressure and lipids with fewer medications. As well, insulin plays a role in sleep apnea, diabetic kidney disease, and retinopathy, depression, sexual dysfunction, urinary incontinence, and knee pain. Add to that better physical mobility, maintenance, and quality of life with lower overall healthcare costs. And this particular trial provided very strong evidence of profound health benefits from intensive lifestyle intervention. And lastly, structured lifestyle intervention trials that include physical activity of at least 150 minutes a week, about 20 minutes a day, not much, and dietary energy restrictions targeting weight loss of just 5% have demonstrated reductions of between 40 and 70% in the risk of developing type 2 diabetes in people with impaired glucose tolerance. We were hoping last Sunday to explore chair-based interventions with our fitness expert Luke Hines, but sadly the weather intervened. But we'll do it, don't you worry. There's research showing the benefits as found in a study titled The Effect of Chair-Based Exercise on Physical Function in Older Adults, a Systematic Review and Meta-Analysis. This review highlights that chair-based exercise benefits several aspects of physical function in older adults. Balance, gait speed, grip strength, and several other physical measurements were often documented as improved in individuals who gained in chair-based exercise. These findings add to a growing body of evidence that supports the importance of both light intensity activity for health and strength and balance activities to preserve physical function. A message that is particularly important for those who are currently inactive, and as such, chair-based exercise can be promoted as a safe and progressive mode of activity for those who may be frail or deconditioned. And in addition, the evidence in this review was mainly of good quality with a low risk of overall bias, suggesting that chair-based exercises should be promoted as simple and easily implemented activities to maintain and develop strength and offset the negative effects of physical inactivity in older adults and vulnerable populations. In this respect, dissemination of easily understandable information by governments, public health agencies, health professionals and community-based organisations is critical to ensuring that older people have clear messages and resources on how to integrate chair-based activity into the home environment to stay physically and mentally healthy at this time. In communicating the benefits of chair-based exercises, public health messaging should reinforce the evidence that every minute counts. Any activity is better than none, and everyone, all ages and abilities, should aim to move more and move more often, while also adhering to the important but often neglected guidance to engage in strength and balance exercise. This messaging will be particularly important going forward, and it is imperative that policy and practice support all members of society to achieve the recommended levels of physical activity to ensure that they are not disadvantaged. I'm impressed with those outlined in the Age Strong program by the Age Strong Network, Peninsula Health, and they offer an illustrated range of these options. And more information is available on request by emailing agestrong@phcn.vic.gov.au. According to a young enthusiastic exercise physiologist colleague of mine, and don't they all appear young these days, chair-based exercise is safe and accessible, so ideal for the more frail person. In her view, it's a cost-effective option that is fun and engaging. Her motto is that any kind of movement is good exercise, thereby receiving the benefits at all levels. And individual discussions with her clients help that teamwork approach of which Dr. Koadlow insisted. I'll visit briefly some simple steps to support movement in care settings. Aged care facilities and home care providers have an important role in promoting mobility. By embedding short, engaging, chair-based programs into daily life, they can help residents and clients stay active, confident, and connected. Here are 4 simple ways to get started. Number 1, incorporate short daily movement sessions. Even 15 to 30 minutes of chair-based activity can improve circulation, flexibility, and muscle tone. Encourage residents to move little and often, for example, before meals or during group activities to build consistency without fatigue. Secondly, focus on functional movements. Prioritise exercises that mimic everyday activities, such as seated leg lifts for walking strength, arm raises for reaching, or gentle torso twists for balance and posture. And this helps maintain independence in daily living. Thirdly, add music and social interaction. Pairing exercise with familiar or upbeat music can make movement sessions more engaging and enjoyable. Group-based chair exercise classes can also boost mood and social connection, increasing participation rates. And lastly, tailor to an individual ability and track their progress. Adapt exercises to residents' mobility levels and health conditions using resistance bands or lightweights where appropriate, and simple progress tracking, for example, number of repetitions, the range of motion improvement helps constantly. In conclusion, the relationship between movement and chronic disease prevention is compelling and underscores the importance of a physically active lifestyle. By prioritising movement, individuals can significantly reduce their risk of chronic disease. Collaborative efforts from individuals, communities and policymakers are essential to create environments that facilitate regular physical activity for all. Thank you very much, and please keep moving.
What an incredible lecture. Gerald, you have certainly delivered an oration worthy of the Koadlow lecture.
Thank you, Helen.
Thank you. Before we finish this evening, I have something to ask of you, and it's something that Gerald asked during the lecture. How do I put this? Sit happens. And what we're trying to achieve is a world record, and that's why we need you. We need you to register, sit and get moving with musculoskeletal health on Friday, the 19th of December for the world's biggest sit-in. This is our attempt at breaking the world record for the largest 30-minute chair-based exercise workout or movement ever held, and we need you. So you can join us in person at Ripponlea Estate in Melbourne or virtually via Zoom for the workout anywhere in Australia or the world. At the in-person event, you can meet our amazing Musculoskeletal Health Awareness Month Ambassador, Gerald Quigley, and our WBSI Ambassador, Luke Hines, as well as our amazing platinum partners, EpiJoint. There'll be good coffee, there'll be gelato and stalls, lots of fun, and we're looking for a festive miracle. We want that world record. So please join us and EpiJoint on Friday, the 19th of December, where we aim to achieve that world record. All information can be found on the WBSI website, wbsi.org.au. So please jump on and register and help us get Australia moving.
Well done.
Now, I want to thank everyone who has joined us this evening. And once again, a huge thank you to Gerald for the amazing lecture. I do want everyone to know that we do have a wonderful thank you gift for Gerald, but I'm not going to grab it and give it to him at the moment because of the camera work we have going on. So on behalf of Musculoskeletal Health Australia, get sitting, get moving, and thank you.